And this is Professor Rivera-Mitu, and today we'll be talking about theories and psychotherapies and psychiatry with psychodynamic and psychoanalytic theories by Freud, Erikson, Sullivan, Jung, and Adler. These theories focus on unconscious processes, early life experiences, and intra-psychic conflict. Freud introduced id, ego, superego, and emphasized defense mechanisms like repression and projection. Erikson expanded Freud's ideas into psychosocial stages across the lifespan. Sullivan emphasized interpersonal relationships as key to personality and mental health. The clinical relevance includes interpreting transference, dream analysis, and understanding client resistance. This table is a comparison of the theory of Erikson versus Freud. As you can see in the core concept, Erikson focuses on the 8 stages of psychosocial development across the lifespan. And the focus of his therapy is understanding current issues through the developmental lens. Examples are identity versus role confusion, generativity versus stagnation, and integrity versus despair. In the clinical setting, this is applied through pediatric to geriatric therapy and guiding psychosocial interventions by age stage. Freud's psychoanalysis focuses on the unconscious drives and early childhood conflict. He focuses on exploring unconscious conflicts and defense mechanism. The key terms are id, ego, superego, and psychosexual stages. His theory is not typically used as primary therapy, however, it informs insight-based approaches and psychodynamic work. Let's look at this case vignette to understand Freud's structural model. In this example, it says a man finds himself unable to commit to a relationship. Though he claims he is not ready, he consistently dates emotionally unavailable people. He dreams of being smothered by a blanket. The explanation of this case example is that the patient's unconscious fear of intimacy may stem from unresolved childhood conflict, which is the id versus the superego. The defense mechanisms like denial and projection may be in play here. This table presents to you Erik Erikson's psychosocial stages, ranging from 0 to 65 years and on. And you can see the different stages there after its age range and the core task that the patient or the client must achieve. It provides an overview of key developmental and psychodynamic theories that have shaped our understanding of emotional and psychological growth. John Bowlby's attachment theory emphasizes how early bonds with caregivers are crucial for emotional development. Mary Ainsworth expanded on this with her research on attachment styles, identifying secure and insecure patterns through the strange situation experiment. And Freud contributed to ego psychology, focusing on defense mechanisms and how the ego develops to manage internal conflicts. Melanie Klein's object relations theory explores how early relationships influence our mental representations of others. Common themes across these theories include the critical role of early childhood experiences, the staged nature of development, the influence of the unconscious mind, and the importance of attachment and relationships in mental health. This foundation helps us appreciate how early interactions shape lifelong emotional well-being and psychological functioning. This table aligns the 3 major developmental theorists. Freud's psychosocial stages focus on how the libido's energy is channeled through different zones over time. Fixation leads to personality issues. Erikson built upon Freud with his psychosocial stages, emphasizing ego development through life crises from infancy to old age. Piaget described cognitive development, explaining how children acquire logical thinking in stages. The overlap all describe stage-based development but differ in focus. Freud is psychosexual, Erikson is psychosocial, and Piaget is cognitive. As PMHNPs, we use Erikson for psychosocial milestones in patients, Piaget for cognitive assessment in children, and Freud to understand unconscious drives and defense mechanisms. Knowing where a patient is developmentally helps guide appropriate therapeutic interventions. It presents Piaget's theory of cognitive development, which describes how children's thinking evolves through four distinct stages. The sensory motor stage, which is birth to 2 years, focuses on sensory experiences and motor actions, highlighting the development of object permanence. The pre-operational stage, 2 to 7 years, is characterized by symbolic thinking, but also egocentrism and difficulty understanding conservation, as illustrated by the example of a child believing a taller glass holds more juice. The concrete operational stage, which is 7 to 11 years, introduces logical thinking about concrete objects, including understanding conservation and reversibility. Finally, the formal operational stage, 12 years and up, involves abstract reasoning and hypothetical thinking. The case vignette of a 6-year-old child attributing feelings to a stuffed animal and misunderstanding quantity demonstrates typical pre-operational behaviors like animism and lack of conservation, reinforcing the theory's practical application in developmental assessment. Margaret Mahler's separation individuation theory emphasizes the process by which an infant gradually separates from the primary caregiver and becomes an individual. This theory highlights the importance of early relationships and their impact on the development of the self. Key concepts include normal autistic phase, which is the initial stage where the infant is focused on internal stimuli, symbiotic phase, where the infant begins to recognize the caregiver as a separate entity but still functions as if they are one, and the separation individuation phase, which is the process of developing a sense of individuality, which includes subphases such as differentiation, practicing, rapprochement, and consolidation. Again, is Margaret Mahler's separation individuation theory, which explains how infants develop a distinct sense of self separate from their caregivers. It outlines key developmental phases starting with the normal autistic phase, where the infant is mostly inward focused with limited awareness of the outside world. Next is the symbiotic phase, where the infant begins to recognize the caregiver as a separate entity, but still experiences emotional unity. The separation individuation phase marks the start of self-awareness and exploration of the caregiver's face and body, often accompanied by stranger anxiety. Within this phase, the practicing subphase involves increased motor skills and environmental exploration, fostering a sense of independence. The rapprochement subphase reflects ambivalence between independence and dependence, with the child seeking reassurance and emotional support. Finally, the consolidation subphase leads to the development of object constancy and a stable sense of self, including an internalized image of the caregiver. This theory highlights the complex emotional and cognitive milestones in early childhood development. We're going to explore key interpersonal and relational theories that highlight how human relationships significantly impact mental health. Hildegard Peplau's work outlines the phases of the therapeutic nurse-client relationship, emphasizing the evolving dynamic that supports patient care. Stack Sullivan's interpersonal theory links anxiety to social insecurity, showing how our interactions shape emotional well-being. Bowen's family systems theory introduces concepts like differentiation of self and triangulation, explaining how family patterns across generations influence individual behavior. And lastly, Sater's communication model focuses on how dysfunctional family communication can contribute to psychological issues. Understanding these theories provides a comprehensive framework for addressing mental health through relational contexts, which is crucial for effective therapeutic interventions and improving patient outcomes. These theories are important for family therapy, group work, and community mental health. Hildegard Peplau is considered the mother of psychiatric nursing. Her theory centers on the interpersonal relationship between the nurse and the patient. Peplau believed the nurse plays multiple roles: stranger, teacher, leader, and more, while guiding the patient through three phases of therapeutic interaction. This model is essential in psychiatric nursing, especially in addressing anxiety and promoting growth through relationship-based care. This slide presents Peplau's model of the nurse-client relationship, which is structured into three key phases. During the orientation phase, the nurse focuses on building trust and clarifying each person's role, setting the foundation for effective collaboration. The working phase involves deeper engagement, where feelings are explored, insights are gained, and behavioral changes are encouraged. Finally, the termination phase is about reviewing the progress made, planning for the future, and bringing closure to the relationship. The included case example highlights a common scenario where a client ends therapy after steady progress, reflecting the natural conclusion of the therapeutic process. Understanding these phases helps nurses navigate the emotional and practical aspects of their relationships with clients, ensuring support is both effective and respectful of the client's journey. This slide outlines the core concepts of Murray Bowen's family system theory, which helps us understand family dynamics and emotional functioning. Differentiation of self highlights how individuals manage their thoughts and feelings, and how well a person can separate their thoughts and feelings and remain autonomous in the midst of family pressures. Higher differentiation enables calm, logical decisions under stress, while lower differentiation leads to emotional reactivity. Triangulation explains how a third party is drawn into conflicts, often seen in parent-child relationships, which temporarily reduces anxiety but perpetuates dysfunction. The nuclear family emotional system describes recurring emotional patterns that can cause marital conflict or issues in one family member. The family projection process shows how parents can pass emotional problems to children, affecting their emotional development. Multi-generational transmission process emphasizes how emotional patterns and trauma are passed down through generations. The theory is often used in therapy to identify maladaptive patterns and help clients become more differentiated and less reactive. Emotional cutoff involves distancing to manage unresolved conflicts, though emotional reactivity remains. Sibling position affects personality and family roles based on birth order. Finally, The societal emotional process reflects how family dynamics scale to societal groups, often leading to polarization and chronic anxiety under stress. The practical takeaway: treat the system, not just the individual. This case vignette highlights a common dynamic in family therapy where a teenager's behavioral issues at school are actually a manifestation of deeper family tensions. The parents report ongoing marital conflict, but do not acknowledge its effect on their child. Instead, the child is labeled as the problem and becomes the focus of therapeutic intervention. This scenario exemplifies the family projection process, where parents unconsciously project their anxieties onto the child, and the nuclear family emotional system, which describes how emotional stress within the family unit is transferred and expressed through one member, often the child. Understanding this helps us see that addressing the child's behavior alone is insufficient. Therapy must also explore and resolve the underlying family conflicts to promote healthier dynamics and emotional well-being for all members. It highlights the foundational principles of cognitive and cognitive behavioral theories, emphasizing how our thoughts directly shape our emotions and behaviors. Aaron Beck introduced the concept of cognitive distortions and automatic thoughts, which are often negative and can lead to emotional distress. Albert Ellis developed rational emotive behavior therapy, focusing on the ABC model, where A is the activating event, B is the belief about the event, and C is the emotional consequence. Bandura contributed the ideas of social learning, self-efficacy, and modeling, showing how people learn behaviors by observing others and believing in their own capabilities. Meichenbaum emphasized cognitive restructuring and self-instructional training, techniques that help individuals change maladaptive thought patterns and guide their own behavior through internal dialogue. Together, these theorists provide a comprehensive framework for understanding and modifying thought processes to improve mental health. These theories guide evidence-based therapies like CBT and REBT. It highlights key behavioral theories centered on observable changes in behavior through reinforcement and conditioning. These theories are action-oriented and focus on how thoughts and behavior are learned and changed. Ivan Pavlov's classical conditioning demonstrated how a neutral stimulus can elicit a conditioned response. Classical conditioning involves associating stimuli with automatic responses. B.F. Skinner expanded on this with operant conditioning, emphasizing how positive and negative reinforcements shape behavior. Operant conditioning is based on reinforcement and punishment. Watson's work in behaviorism, including the famous Little Albert experiment, showed how fear responses can be conditioned. Thorndike's law of effect laid the groundwork for operant conditioning by establishing that behaviors followed by satisfying consequences are more likely to recur. Together, these theories provide a foundation for understanding how behavior can be modified through environmental stimuli and consequences. This table compares the foundational behaviorist approach with CBT. Behaviorism focuses on observable behavior and the environment's role in shaping it, primarily through reinforcement and punishment. Think of Skinner and Pavlov here. CBT, on the other hand, integrates cognitive theory. It recognizes that thoughts influence feelings and behaviors and targets those maladaptive thoughts to drive change. While both emphasize behavior change, CBT expands the scope to include cognitive restructuring. teaching clients to challenge and reframe distorted thinking. The key difference: behaviorism treats the symptom behavior directly. CBT treats the underlying thought process. In therapy, a behaviorist might use a reward system, while a CBT therapist would explore what beliefs drive a client's avoidance or distress. Let's dive a little bit deeper into cognitive distortions identified by Aaron Beck, which are common patterns of negative thinking that can contribute to emotional distress. This table lists 5 distortions with relatable examples: all or nothing thinking, catastrophizing, emotional reasoning, mind reading, and overgeneralization. For instance, all or nothing thinking involves seeing situations in black and white terms, like believing a single test failure defines your entire worth. Catastrophizing exaggerates the severity of events, such as assuming a headache signals a brain tumor. Emotional reasoning equates feelings with facts, while mind reading involves assuming others' negative thoughts without evidence. Overgeneralization takes one negative event and applies it broadly. The case vignette of Jason illustrates how these distortions can impact self-esteem and perception. The slide encourages using cognitive behavioral therapy techniques to identify and challenge these distorted thoughts, promoting healthier thinking patterns and emotional well-being. This slide explores Albert Bandura's concept of self-efficacy, which is essentially the confidence in one's ability to take the necessary actions to handle future challenges. High self-efficacy is crucial because it directly impacts motivation, how we behave, and our ability to bounce back from setbacks. Bandura identifies 4 key sources that shape self-efficacy: mastery experiences, where success strengthens belief in our capabilities while failure can weaken it; vicarious experiences, which involve learning through observing others succeed; verbal persuasion, meaning encouragement from others that can boost our confidence; and physiological and emotional states, where feeling calm and positive enhances self-efficacy, whereas anxiety can diminish it. Understanding these sources helps us foster stronger self-belief in ourselves and others, which is vital for personal and professional growth. This slide focuses on Bandura's concept of reciprocal determinism, which highlights the dynamic interplay between behavior, personal cognitive factors, and the environment. Each of these elements influences and is influenced by the others, creating a continuous feedback loop. Central to Bandura's theory is self-efficacy, like we mentioned before, or the belief in one's ability to succeed in specific tasks, which drives motivation and behavior change. The visual illustrates how mastery experiences, social modeling, and positive feedback contribute to building self-efficacy, ultimately shaping behavior. If you see these key terms in the PMHNP exam, think of Bandura's social cognitive theory as the most possible answer. This case vignette illustrates how Bandura's self-efficacy theory can be applied in clinical practice to support a young person struggling with public speaking anxiety. Maria, a 16-year-old, has long avoided situations requiring presentations. The nurse practitioner uses a multifaceted approach based on Bandura's 4 sources of self-efficacy. Mastery experience, by guiding Maria through practicing a short speech; vicarious experience, by having her observe a peer with similar fears succeed; verbal persuasion, through consistent encouragement; and emotional state regulation by teaching anxiety management techniques like deep breathing and guided imagery. These interventions collectively helped Maria build confidence, leading to her successful classroom presentation and increased self-efficacy. This example highlights how addressing both internal beliefs and external feedback can motivate behavioral change and improve outcomes in anxiety and related conditions. Let's explore the two foundational theories of behavioral learning: classical conditioning and operant conditioning. Both play crucial roles in mental health interventions and behavior therapy. Classical conditioning, which is developed by Ivan Pavlov, who discovered that dogs could learn to salivate to a bell if it had been repeatedly paired with food. This involves involuntary, automatic responses. Key in the development and treatment of phobias, anxiety disorders, and conditioned emotional responses. Example in therapy is systematic desensitization, gradually pairs relaxation with fear-provoking stimuli. In operant conditioning, which was developed by B.F. Skinner, who studied how consequences shape behavior, it focuses on voluntary behaviors and their outcomes. This includes positive reinforcement, which is adding a reward; negative reinforcement, which is removing something unpleasant; positive punishment, which is adding an aversive stimulus; and negative punishment, which is removing a reward. This is used in parent training, behavior modification, ADHD treatment, and substance use programs. Whereas classical conditioning teaches association between two stimuli, operant conditioning teaches us that behavior is shaped by its consequences. Let's bring these theories to life with a clinical vignette involving Jordan, a 9-year-old presenting with school refusal and symptoms of anxiety. Jordan reports feeling nauseous every morning before school. Upon assessment, we learned that he had a panic attack during a math quiz weeks ago. In classical conditioning terms, the panic attack was the unconditioned stimulus, which naturally led to nausea and fear, the unconditioned response. Over time, the site of the school building, originally a neutral stimulus, became associated with that negative emotional experience. Now, just approaching the building triggers the same anxious and physical responses. This is a classic example of how anxiety can become conditioned. To help Jordan, we use systematic desensitization, a therapeutic method based on classical conditioning. We gradually pair the anxiety-provoking stimulus, which is school, with calming techniques like breathing exercises until the response becomes neutral or even positive. In operant conditioning, let's look at how it can support behavior change in the same case. Jordan's parents started a reinforcement chart. Each time Jordan walks into school without resisting, he earns a sticker. After 5 stickers, he gets a reward, like extra playtime or a special outing. This is positive reinforcement, adding something desirable to encourage the behavior. On the other hand, when Jordan refuses to go or begins to tantrum, his parents withhold screen time. This is an example of negative punishment, removing something desirable to reduce unwanted behavior. Over time, consistent reinforcement and consequences help Jordan internalize the behavior of entering school calmly. Teaching takeaways. This case highlights how both classical and operant conditioning can be integrated in therapy. Classical explains the development of the fear response. Operant provides a framework for changing behavior through reinforcement. Understanding the why behind behavior and how to strategically intervene using evidence-based behavioral principles is essential for psychiatric mental health providers, especially in pediatrics and school-based settings. Here's some keywords to watch for in exams. If you see these keywords, think of either classical or operant conditioning. For classical, stimulus response, association, Pavlov, phobia, desensitization, or CR, which is conditioned response. That's the learned response to a previously neutral stimulus, such as salivating to a bell. CS, which is conditioned stimulus, a previously neutral stimulus that, after association with the unconditioned stimulus, triggers a conditioned response like the bell. UCS, which is unconditioned stimulus, a stimulus that naturally and automatically triggers a response without prior learning, like food causing salivation. For the operant conditioning, look for keywords like reinforcement, Skinner, voluntary behavior, shaping, token economy, and behavior modification. Now let's look at humanistic and existential theories. They're all focused on self-actualization, free will, and personal growth. Rogers developed client-centered therapy, where empathy, genuineness, and unconditional positive regard are key. Maslow's hierarchy outlines basic to transcendent needs, which are essential for holistic care. Existentialists like Frankl and Yalom emphasize meaning-making in suffering and the anxiety of choice. These models are strength-based and often used in recovery-oriented and trauma-informed care. Look back at some of the theories that we just talked about. This table offers a concise comparison of 4 major psychological theories, highlighting their unique contributions to therapy. Bowlby's attachment theory emphasizes the importance of early emotional bonds and is often applied in therapies addressing relationship issues, trauma, and grief. Rogers' person-centered therapy focuses on creating a supportive therapeutic alliance through empathy and unconditional positive regard, fostering client self-awareness and trust. Erikson's theory outlines 8 psychosocial stages across the lifespan, helping therapists understand clients' current challenges within a developmental context, useful from childhood to old age. Freud's psychoanalysis explores unconscious drives and early conflicts, providing insight into defense mechanisms and personality structure, though it is less commonly used as a primary therapy today. Together, these theories provide diverse frameworks for understanding human behavior and guiding clinical interventions tailored to individual client needs. On to nursing theories. These theories integrate nursing practice with holistic care models. Watson emphasizes caring science, which is about transpersonal care and the nurse-client relationship. Orm is about self-care deficit theory, where the clients need support for self-care. Leininger is transcultural theory, which is understanding and respecting cultural differences in care. Roy is the adaptation model, which focuses on how individuals respond to environmental stimuli. These are essential in meeting BRN continuing education provider and holistic care standards. This table contrasts three cornerstone nursing theorists who inform PMHNP holistic care. Jean Watson emphasizes caring and the transpersonal connection in nursing. It's about presence, empathy, and spiritual healing. Dorothy Oram focuses on self-care. Nurses intervene when there's a self-care deficit, but aim to restore patient independence. Leininger introduced transcultural nursing. Her theory highlights the importance of understanding cultural context and providing care. Each theory guides different aspects of therapeutic interaction. Watson for empathy, Oram for empowerment, and Leininger for cultural respect. PMHNPs integrate all three when building rapport, planning treatment, and respecting patients' lived experiences. Here we are going to talk about biopsychosocial, recovery, and systems models. Their focus is on integration of biological, psychological, and social environmental factors. The biopsychosocial model was developed by George Engel as an alternative to the strictly biomedical model. It emphasizes the interconnectedness of biological, psychological, and social factors in understanding health and illness. This model encourages PMHNPs to consider neurobiology, mental health symptoms, and environmental or cultural stressors in assessment and treatment. For example, depression may be caused by genetic predisposition, bio, negative thinking patterns, psych, and lack of social support, which is social. It aligns well with holistic nursing, trauma-informed care, and interdisciplinary approaches. Important keywords to remember: integrative care, holistic assessment, patient-centered, or biopsychosocial spiritual. The recovery model is a client-centered, strengths-based approach rooted in mental health advocacy. It emphasizes hope, empowerment, personal responsibility, and meaningful life goals rather than just symptom management. The key principles include self-direction, peer support, respect, and holistic care. The model recognizes that recovery is not linear. Setbacks are expected and part of the journey. The PMHNP's role is to support autonomy, help set realistic goals, and foster collaborative treatment planning. This is often used in community mental health, substance use treatment, and trauma-informed practice. Keywords to remember are peer support, empowerment, resilience, strengths-based, and client-driven care. The systems theory views individuals as part of complex systems, like families, communities, cultures, where change in one part affects the whole. Originating from general systems theory, it's applied in family therapy, group therapy, and organizational psychology. Bowen family systems theory is a subtype that introduces concepts like differentiation of self, which is the ability to maintain individuality in close relationships, triangulation, bringing in a third party to relieve anxiety, multi-generational transmission, which are patterns across generations. PMHNPs using systems theory look beyond the individual to family dynamics, social context, and interaction patterns. Keywords to look for are homeostasis, feedback loops, family roles, triangulation, and interconnectedness. Slide illustrates the trans-theoretical model, which explains how individuals progress through different stages when changing behavior. The model is cyclical, highlighting that change is a process rather than a single event. It begins with pre-contemplation, where individuals may not yet recognize the need for change. Next is contemplation, where they start considering change but have not committed. Preparation follows, involving planning and small steps toward change. The action stage is where active modifications occur. And finally, maintenance focuses on sustaining those changes over time. The arrows in the diagram show that people can move back and forth between stages, reflecting the non-linear nature of behavior change. Understanding this model helps tailor interventions to support individuals effectively at each stage of their journey. Here's some tip for the board exam. When answering exam questions, identify the theory's primary focus. If the question is about unconscious conflict, that's psychodynamic. If it's about distorted thinking, that's cognitive or CBT. If it focuses on reinforcement, that's behavioral. If it's about empathy and personal growth, that's humanistic. If the emphasis is on the nurse-client dynamic, that's nursing or interpersonal care. Let's see how much you retained. Let's do some review questions. Question 1. Which of the following best describes the primary goal of cognitive behavioral therapy, or CBT? A. Uncover unconscious conflicts. B. Identify and restructure maladaptive thoughts. C. Strengthen the therapeutic alliance. Or D. Promote free association. You can pause here if you need time to think. And the correct answer is B. Identify and restructure maladaptive thoughts. CBT focuses on helping clients recognize and reframe distorted or unhelpful thought patterns, which are cognitive distortions, which influence emotions and behaviors. A, which is uncover unconscious conflicts, this is a core goal of psychoanalytic therapy, not CBT. Answer C, strengthen the therapeutic alliance. While important in all therapies, it's not the primary focus of CBT. And D, promote free association. This is also a psychoanalytic technique used to uncover repressed material. So again, some keywords to look out for in PMHNP board questions for CBT are automatic thoughts, cognitive distortions, restructuring, evidence-based. Question 2. According to Bowen's family systems theory, which concept reflects the ability to maintain autonomy while staying emotionally connected to others? A. Enmeshment. B. Differentiation of self. C. Triangulation. Or D. Emotional cutoff. Feel free to pause if you need more time. And the answer is B. Differentiation of self. This refers to the capacity to balance emotional and intellectual functioning while maintaining closeness with others, which is central to Bowen's model. A. Enmeshment refers to overly close relationships with blurred boundaries, often used in structural family therapy, not Bowen. Triangulation, letter C, involves drawing a third party into a dyadic conflict, not autonomy. And D, emotional cutoff, means withdrawing from others to manage unresolved issues, not healthy differentiation. Some keywords to look for that may be connected to Bowen's family systems theory is family dynamics, emotional boundaries, and multi-generational patterns. Number 3, in psychodynamic therapy, transference refers to A, the therapist's emotional reaction to the client, B, the client projecting unconscious feelings onto the therapist. C, a deliberate therapeutic confrontation. Or D, the client's resistance to therapy tasks. Pause here if you need more time to think. And the correct answer is B, the client projecting unconscious feelings onto the therapist. Transference is when clients redirect emotions originally felt toward important figures like their parents or loved ones onto the therapist. A, therapist's emotional reaction. This is countertransference, not transference. C, therapeutic confrontation is a strategy used in some therapies like Gestalt, not a definition of transference. D, resistance is related but distinct. It's a defense mechanism to avoid distressing material. Question 4. Which theorist is known for developing the hierarchy of needs, culminating in self-actualization? A, Erik Erikson. B, Abraham Maslow. C, Carl Rogers. Or D, Jean Piaget? Correct answer is B, Abraham Maslow. Maslow's humanistic theory proposes that humans have a hierarchy of needs: physiological, safety, love and belonging, esteem, and self-actualization at the top. Erikson, letter A, is known for psychosocial development theory across the lifespan. C, Carl Rogers, developed person-centered therapy and emphasized unconditional positive regard. That's a keyword. And D, Piaget, focused on cognitive development in children. And here's our last question. Question 5. A 22-year-old college student presents to therapy feeling anxious and disconnected. During sessions, the PMHNP practices active listening, offers empathy, and avoids giving direct advice. Over time, the client begins to explore their authentic feelings and express previously hidden fears and desires. This therapeutic approach is most consistent with which theoretical model? Is it A, CBT, B, psychodynamic therapy, C, humanistic therapy, or D, solution-focused therapy? You can pause if you need more time. And the answer is C, humanistic therapy. This case reflects Carl Rogers' person-centered approach, a hallmark of humanistic therapy. The therapist creates a safe, accepting environment where the client can grow through empathy, genuineness, and unconditional positive regard. The therapist does not direct the client, but instead facilitates self-exploration. Choice A, CBT, would involve identifying and restructuring negative thought patterns and assigning homework, not evident in this scenario. B, psychodynamic therapy, would focus on exploring unconscious conflicts and childhood experiences, often through transference, which is not described here. And D, solution-focused therapy, emphasizes future goals and finding exceptions to problems rather than deep emotional exploration or self-actualization. Some keywords to remember for Carl Rogers: person-centered therapy, unconditional positive regard, and again, empathy and genuineness. Thank you for watching. If you found this video helpful, please give it a thumbs up, subscribe to my channel, and share it with your fellow nursing students. Your support helps me reach more students and provide valuable content. Remember, together we can make a difference in our nursing journey. Stay curious, stay compassionate, and keep learning. Until next time, this is Professor Rivera-Mitu. Stay strong, stay smart, and keep caring.